This conference will now be
Good
recorded.
morning, sir. Good morning, sir.
Good morning to all of you. Okay. The last class, actually, we were discussing about pneumothorax. Pneumothorax. So, what are the various types of pneumothorax? Kalyan, pneumothorax.
Tension pneumothorax, hydropneumothorax.
It's classified into actually spontaneous pneumothorax and traumatic
Spontaneous and
pneumothorax.
traumatic.
Spontaneous and traumatic. Again, spontaneous, primary spontaneous, secondary spontaneous. Like that. Primary spontaneous, I told you, is where there is no lung disease. There is no lung disease. It occurs actually in young males. All young males are between 18 to 30 years. Here, secondary spontaneous pneumothorax occurs in case of people who have got lung disease like pulmonary tuberculosis, COPD, cystic fibrosis, emphysema, like that. There, the patient presents with spontaneous, secondary spontaneous pneumothorax. The second one is traumatic. Traumatic again, traumatic and pneumothorax. Non-iatrogenic and it may be iatrogenic. Non-iatrogenic, it may be due to stab wound or gunshot wounds or road traffic accidents. Stab wounds, gunshot wounds, road traffic wounds may occur. And iatrogenic means it may be because of the system, that is therapeutic measures like suppose like in cases of insertion of central lines, CPRs, mechanical ventilation, and all the iatrogenic. It is done actually in the good intention, but unfortunately, sometimes the complication may occur, like in case of central vein insertion. There, the patient may develop pneumothorax, or the patient may develop in case of CPR. Patient may develop in case of thoracocentesis, or the patient may develop in case of actually pericardiocentesis, like that. In all those iatrogenic, sometimes the pneumothorax may be present. For clinical signs, so of course, three types. You said pneumothorax, tension pneumothorax, and hydropneumothorax. Hydropneumothorax, of course, the complication in case of pleural effusion. Usually, it may be due to pleural effusion, and sufficient care is not taken to remove the fluid. The air maintained, it may cause hydropneumothorax. And of course, in pneumothorax, and it is not drained properly also, the infection may occur, it may cause hydropneumothorax, of course. But otherwise, they are closed, open, and tension. Tension in pneumothorax is a medical emergency. It's a medical emergency. Pathophysiolo, why pneumothorax occurs? Pneumothorax is very important because the body does not allow the air to enter into the pleural cavity, because of course that's very well. So minus 5 centimeters of water, that is subatmospheric pressure will be there. So as well, what happens, the both parietal and visceral flora, actually they are pulled. They are pulled out. They are pulled out. They are pulled out because of the negative pressure in the pleural cavity. It is minus 5 centimeters of water. Of course, that is pulled out. The lung is pulled out. Lung is pulled out, pulled in. That is collapses because of the elastages and proteases in the lungs. So, of course, the non-proteases will be there, non-elastases will be there. That is, its lung also tries to pull in, collapses, and the parietal flora and other things they try to pull out. So that's why the lung will not collapse, will not collapse. So that's why we are able to breathe. Of course, what are the signs? Signs may be asymptomatic. Maybe asymptomatic in a case of small pneumothorax, like in case of primary spontaneous pneumothorax, and sometimes in some pneumothorax, in like in case of COPD and all those things, because that's a closed pneumothorax. Closed pneumothorax sometimes, and sometimes it may be open pneumothorax. Like what is open pneumothorax? Open pneumothorax example is bronchopleural fistula. The pleural cavity is directly exposed to the outside atmosphere. That is, it is the bronchopleural fistula. That is when there is an opening in case of the pleura. The air may enter into the pleural cavity, but because of the patent bronchi, because the patent bronchi, it is direct in contact to the atmosphere. That is known as bronchopleural fistula or open pneumothorax. Of course, tension pneumothorax, one-way valve operation is there. That is, the mechanism is it acts as a one-way valve. The air may enter into the pleural cavity during inspiration. During expiration, it won't go out. Like in case of open pneumothorax, it will go out during expiration. But here, in case of tension pneumothorax, air cannot go out because of the one-way valve mechanism. It allows the flap will be there. The pleura, that is in case of visceral pleura. Here, in case of spontaneous pneumothorax, it acts as a one-way valve. But in case of traumatic pneumothorax, also it may cause sometimes tension pneumothorax. That is the flaps are opening in case of parietal pleura. It acts as a one-way valve. The air may enter, suppose in case of stab wound, in case of gunshot, in case of traumatic injury. There, the opening in actually parietal pleura. In case of visceral pleura, in case of cystic fibrosis, that is in case of COPD, emphysema, pulmonary tuberculosis, lung abscess, all those conditions, the flap will be there in the visceral pleura, which is actually in continuity with the lung. So, of course, the tension pneumothorax. What are the signs and symptoms? I just repeat. The patient will develop chest pain, severe chest pain, breathless will be there, tachycardia, palpitation, sweating, and then hypotension, and then respiratory distress. It's an emergency, medical emergency. If it is not relieved immediately, the patient will die. Coming to the investigations today, here today I will be focusing many X-rays. X-rays will not, so that you will not miss pneumothorax. Pneumothorax, of course, if it is like this, actually, of course, we can easily find out. But sometimes subtle signs are there. Suppose is there, lung is pushed, collapse of the lung is like this. Is all air. And what you find actually the lung, the linear shadow, that is visceral pleura will be there. Lack of lung markings. Lung markings will be there. Markings of the lung like this. Bronchovascular marking will be there. There, when the air in the pleural cavity, lung markings will not be there. You will not find any lung markings. Here, markings are here. Markings are only up to this place. Like here, lung markings are here. But there are no lung markings are here. These are here. The edge of the lung is here. Here, pneumothorax, no lung markings. It is the collapsed lung. This is the collapsed lung. Of course, another investigation is actually this air is there. Pneumothorax means what you find actually is that air, because of the bronchoscopy markings, తెల్లగా కనబడతాయి. But in case of pneumothorax, what you find actually, you will find dense dark lung, that is hypertranslucent. Hypertranslucent, the lungs will increase. Hypertranslucency of the lungs will increase. Hypertranslucence of the lung will increase, like this, more hypertranslucent. That will increase. And lung, the collapsed lung, you will find markings of collapsed lung. If it is pneumothorax is more very big, actually that may be pushed. The mediastinal structure may be pushed to the opposite side. It may be pushed to the opposite side, of course. This is actually small air, that is actually in case of primary spontaneous pneumothorax. More X-rays we are focusing today. This is pneumothorax, all pneumothorax. The lung is, of course, the collapsed lung is here. And the mediastinal structure is pushed to the opposite side. This is left side. Right side is here pneumothorax. Lung is collapsed here. The heart is pushed towards more left side. Mediastinal structures are also pushed to the left side. So here is a big CT scan. Unilateral hypertranslucence shows hypertranslucence affect the entire right lung. Large bulla, of course, star on the right side, causing considerable compression of mediastinum. Compresses the mediastinum. It pushes towards the left side. Here, of course, is the same. Of course, this hydropneumothorax. This is hydro, and this is pneumo. All things in the air. Pneumothorax, loculated pneumothorax. In other exercise is present in loculated. Just how will you say this is pneumothorax? I told you the bronchovascular markings will be absent. You are finding bronchovascular markings. Actually, these are present up to this age. So here they are absent. Only hypertranslucency gas shadow is there. Hypertranslucency gas shadow is there. Markings are not there. Here their hypertranslucent gas shadow is there. The loculated pneumothorax, just like loculated prolifation. Ultrasonography is the best technique, more sensitive than X-ray. Unstable patient who cannot go outside. Span air accumulates in the anterior region of the chest. Second to fourth intercostal space in the mid-clavicular line. Mid-clavicular line it will be there. It is present in the anterior aspect actually, but of course in case of EAV chest there actually it is present actually laterally. That will be, but present laterally. Of course, it's not important. So what is more important actually when you see the X-ray? X-ray you find hypertranslucency grass shadows will be there. Hypertranslucency grass shadows will be there. And then bronchovascular markings will not be present. And if it is a big pneumothorax or tension pneumothorax, and the trachea 50 is there to the opposite side. and the mediastinal strictures are also shifted to the opposite side. But this is not very important for postgraduates. Hydropneumothorax, deep sulcus site. In supine patient, in the ICU, if the patient's X-ray is taken, pneumothorax subpulmonic, that is here, that is present in the below the lung, that is deep sulcus site. Here you will find the sulcus is only like this. This is narrow one. The costophrenic angle is present, not obliterated, but here that is narrow, small. But here deep sulcus, because of the presence of air, with the presence of air, subpulmonic area is all air. There is a diaphragm, is all air. That is known as deep sulcus site. Bullous formation, just like this is in case of COPD or emphysema, bullous formation. This is bulla. Actually, you don't find markings are not very prominent here. Maybe of course behind the lung marking, but otherwise actually this will not be there. Double diaphragm site. In case of pneumothorax, air in the right hemithorax displaces both the dome of the diaphragm. This is and the anterior costophrenic angle. In this patient, the large right side pneumonia is a deep sulcus sign. For the deep sulcus sign is there. Double dome. This is one. And this is also here present in double diaphragm sign. You will find one like this and one like this, double diaphragm. Both the dome of the diaphragm displaces here, both the diaphragm here and yellow arrow. Both these are the white, this is the original diaphragm. This is the second. This is also because of the presence of air. Anterior costophrenic angle. Large right sided pneumothorax with a deep sulcus sign. So double diaphragm sign, deep sulcus sign, and actually pushed mediastinal structure to the opposite side, pushed trachea, and all those are finding in the X-rays. Of course, hydropneumothorax is known as this. Later on, I'll just take a few minutes, like 4 or 5 minutes, about hydropneumothorax in the last. This is known as, what is this? What is this, Pawan Kalyan? What do you call it? What do you call it? Air fluid.
Air fluid level.
This is air. This is fluid. Air fluid is because you say you percuss, then you will get a straight line. It is known as straight line dullness because of the presence of air pushes fluid like this and the straight line. So what is Ellis curve? Ayesha, what is Ellis curve?
Sir, sorry, sir, can't hear.
Ellis S-shaped curve. Ellis, E-L-L-I-S, S-shaped curve. Ellis S-shaped curve that is present in case of moderate sized pleural effusion. In case of moderate sized pleural effusion, if you percuss in all the three areas, anterior, lateral, and posterior. You will get levels at different points. You mark all the 3 points, and it will assume the shape of S, more or like S, that is known as Ellis S curve. Why it is different points we get in the axilla, that is the highest. Highest in the axilla, lowest in the highest dullness, highest point of dullness is present in the axilla. Lowest is present in the spine or around the spine. That is known as L-shaped curve. Why highest dullness in the axilla? Because both the parietal and visceral fora, they will be in close contact, but there is a small gap is present. So because of this gap or because of the separation, it is partial. Because of the what happens, the air, the water or the fluid that is there actually rises because of the capillary suction. Because of the capillary suction, it rises more in the axilla. So that's why highest in the axilla, lowest in spine. But in case of pneumothorax, of course, dense hypertranslucence will be here. But when there is fluid, of course, hydropneumothorax like this. Of course, it's not important for you. So, of course, different diagnosis, very different diagnosis there. Because the patient develops chest pain. Because the patient develops chest pain, you can suspect pulmonary embolism. After pulmonary embolism, dissecting, and what happens? There will be tachycardia, hypotension will be there, chest pain will be there, patient actually collapses, respiratory distress will be there. Esophageal spasm also, chest pain. Rupture, pericarditis, chest pain. Myocardium, of course, you know very well, chest pain. So, congestive cord, pneumothorax, prolapsation, ARDS, asthma, foreign bodies. And what is the treatment? Now, the main important investigation is only actually X-ray chest, ultrasound abdomen, ultrasound, of course, chest and abdomen, and then CT chest, MRI chest. So that will conclude our investigations. Now, coming to the treatment part. So in case of actually, mostly it may be asymptomatic, in case of small pneumothorax, and it may be, the patient may be gravely ill. The patient may be gravely ill in cases of tension pneumothorax. Case of tension pneumothorax. So the patient actually presents with severe breathlessness, cyanosis, tachypnea, tachycardia, hypotension, sweating, and then respiratory distress will be there. So asymptomatic. Asymptomatic means there is of course small pneumothorax. The familial tendency will be there. Long-term recurrence is a familial tendency, it may recur. Of course, that is not harmful to the patient. But here, of course, the advocates so many hospitalized British Thoracic Society, clinical pressure, chest tube, because in case of so actually, in case of tension pneumothorax, outpatient care occur in asymptomatic patient, emergency department care, prolonged periods of observation, inhibition, manual aspiration, placement of one-way gun. So what you should do in case of tension pneumothorax is Immediately what you have to do, you have to actually aspirate the actual air before taking X-ray. Just by taking this history and examination, after clinical examination, you come to a reasonable diagnosis of tension pneumothorax. That is with mediastinal structures. Breath zones are absent. Trachea is shifted to the opposite side. Of course, then if you percuss, you will get hyper-resonant node. Then you definitely you must come to a decision that is a case of tension pneumothorax. So what you have to do, immediately you have to decompress. That is more important. Then only you can save the life of the patient. But if you send it for X-ray, chest or CT scan, then you may lose some time and you may also lose the patient. What you immediately have to do is, immediately you have to do a wide bore needle. Wide bore needle, you know, about 14 to 16 size. What that is IM injection, what actually you have to use, actually you'll use 24 or 22 size. So more than that, you may, you know, that is in case of CSF training, it may be, it may present from 21 or 20 onwards, 24 onwards, 24 and then 22, 21 like that increases. As the number increases, the number increases, it will become narrow. As the number decreases, it will move. Like 21 needle. 21 needle will be actually, that is bigger. The size will be bigger. So like that, that 16, you will have to use either 14 or 16 bore needle. 14 or 16 bore needle. Then where you have to introduce, you have to introduce into the mid-clavicular line in the second intercostal space. Above the rib actually you have to introduce. Why you have to use above the rib? You all know that there is neurovascular bundle. Neurovascular bundle is present below the rib. Vein, that is vein artery now. Vein artery now, that is neurovascular bundle is present below the rib. So you must always that intercostal drainage tube or needles, whatever you want to put in intercostal space, you must always put above the rib. Above the rib you have to choose. Chest tube placement. The thoracoscopy you have to do above the rib. Above the rib. Like this. So then you must actually take a 14 to 16 gauge needle and put it and try to decompress. Immediately when you put needle in the intercostal space in the second space, anteriorly mid-clavicular line, you will hear a hissing sound. That is, air is coming out. Air is just coming out of the needle. That is hissing sound. But you should not remove the needle. Then you have to take the patient to X-rays. Then you can do X-rays. You can take the patient to X-rays. And then keeping the needle there only, then you must try to do thoracostomy tube. Thoracostomy tube you have to put. Chest tube, that is chest tube you have to put. The space you have to use actually the anterior axillary line. Anterior axillary are just in front of the mid axillary line in the fifth intercostal space. Fifth intercostal space you choose. Fifth intercostal space you have to choose. And then you have to put the chest tube there. Anterior axillary line. Of course, this adder mid-clavicular line will be there like this. Somewhere here you have to put it, needle. But chest tube, when you want to put it, that should be put. This is the nipple. Fourth space. This is the fifth space, anterior axillary line. Anterior axillary line you have to put. And you have to connect tube into, of course, this is the, actually, previously this is the latest actually. But what you are using actually now, in India also, you may be using, of course, some hospitals you may be using this drainage device. But otherwise, you have to use suction. Underwater seal will be there. Because of course, actually, so many latest apparatus will come in. Otherwise, previously now you're using only one bottle, underwater seal that will be there connected. Actually, the tube connected, the tube will be connected, and into this tube will connected to the underwater seal into the bottle like this, like this. Underwater bottle, one bottle will be there. It will go in like this. The water will be there about 2 centimeters. Depth of water will be there, and out that is, there is an outer valve or opening will be there. That is, air enters like this, absorbed in water, and then also it may go out like this. That is one bottle. Nowadays, and one bottle has become now the latest is it has become two bottle, and again it also become actually that is three bottles. Three bottles will be there here. The latest is like this. 2, 3 like this. Of course, other things actually you have to do like this. Assess the ABC, the other treatment, that is treatment ABC, and then vital signs, pulse oximetry, administer oxygen to the patient, ventilate the patient, needle decompression, of course, immediate left and pneumothorax, ultrasonography, open pneumonia. Bedside ultrasonography is very important because when you are doing this tube insertion, tube thoracostomy, then sometimes it may cause cardiac tamponade. It may cause massive pulmonary embolism or hypovolemia or tension pneumothorax again. Of course, clinical diagnosis, high index of suspicion is important. Thoracic decompression is important for all healthcare purposes. Establish intrathecal intubation. Insertion of needle again he has given here. Chemotherapy insertion 14 to 16 days. Catheter needle first to insert the needle. Needle first introduced, then the air is let out, and then you have to put a case catheter there. Catheter there. Second anterior intercostal midclavicular line over the third rib, In the fourth or fifth intercostal space over the superior rib margin in the anterior axial line. That is chest drain. The catheter is connected to T-way stopcock and a large volume. You have to put the needle just above the rib. You have to avoid this lower portion of the rib because neurovascular bundle is there. There, the needle is anterior axial line is this. This anterior axial line. Here you have to. Of course, primary spontaneous pneumothorax is small. Pneumothorax is small. Then I ask the individual to stop smoking because it's very common in smokers. Large volume of air is present that is drained by aspiration by using a pigtail catheter. Of course, that is what we have seen today. Left to the suction water is recommended. Strong suction should not be used with primary spontaneous pneumothorax because of delayed presentation, increased risk of re-experience pulmonary. This is fifth intercostal space, anterior axillary. This is mid axillary. This is posterior axillary. Here you have to put nipple here, fine here. You have to put in the fifth intercostal space. You have to put in the fifth intercostal space. And of course, here just underwater seal here doesn't like this. And there is opening here outside. Of course, the another latest treatment is video-assisted thoracoscopic surgery (VATS). So minimally invasive surgical technique. VATS can replace a traditional thoracotomy, which uses one large incision to gain access to the chest. The minimally invasive procedure typically results in less pain, faster recovery time, and the patient among other advantages. The small this is VATS. Video thoracoscope. Small incision, less pain, less complications. What are the complications? The complications are hypoxemic respiratory failure, cardiac arrest, pneumothorax, bronchopulmonary fistula, pulmonary edema, lymphedema, pneumomediastinum, pneumopericardium, pneumoperitoneum, pneumothorax. Complications of surgical procedure, infection of the pleural space may be there, persistent air leak, pain, of course. Persistent air leak may be infection of the pleural space. Do not take enough precautions. Recurrent pneumothorax, present in case of about 20%. Causes are cystic fibrosis, lung cyst, emphysematous bullae, bronchogenic carcinoma rupture, honeycomb lung, contaminated pneumothorax. Here, I just take about few minutes to tell you about hydropneumothorax. So, what is hydropneumothorax, Ayesha? Hydropneumothorax.
Sir, air in the pleural cavity.
Hydropneumothorax is the presence of both air and water, or air and fluid in the pleural cavity. That it may be usually it's a complication of pleural effusion. Pleural effusion, improperly drained pleural effusion. So when you want to do thoracocentesis of pleural effusion, you have to use three-way valve. So that the air may not enter from outside. So one way and one. Then you take the fluid and again close and again open, again take the fluid, again close, like that. One you have to use three-way valve. So if you do not use three-way valve, then air may enter inadvertently into the pleural cavity. It may cause hydropneumothorax. So there are different. I just told you the one differentiating point, that is L is a shaped curve and a straight line dullness. There are three or four more signs. What are those 4 or 5 signs of hydropneumothorax? Pawan Kalyan? Signs. Harika? Other than Ayesha? Pawan Kalyan? Harika? Okay, Ayesha, tell me one sign. One sign is, that is yes, straight line dullness. Straight line dullness, one sign. What are other signs? Yes, it is the sign has to
Flash.
start. Huh? One is S straight line dullness. What are other S signs?
So shifting dullness,
Very good. Shifting dullness.
splash sign,
Succussion splash.
Sound of a
Yes.
coin.
Sound of a coin. Succussion splash. Shifting dullness. Straight line dullness. And then sound of a coin. One more. Shift of trachea. Shift of trachea to the opposite side. So shift of trachea. Straight line dullness. Succussion splash. Shifting dullness. Sound of coin. 5 S signs. 5 S signs of hydropneumothorax. That is, you must always remember, because suppose the patient, patient is put in case of examination in university. Suppose the patient, known case of pleural effusion, tried aspiration 2 or 3 days prior. Suppose the patient is put to you, then what you have to do is you must always check. The dullness. That is, straight line dullness is there, or Ellis shape curve is there. You must always make sure that it has not become hydropneumothorax. It has not become hydropneumothorax. It's one of the common complications of pleural effusion. That is very important. For that, you have to check all these 5 signs. Shift out trachea like that. Shift out trachea, succussion splash, sound of coil like that. And dullness, straight line dullness important. So whenever in the case of pleural effusion, you must always try to percuss anteriorly, laterally, and posteriorly, and make 3 points. Connect all the 3 points. If it is straight line, that is hydropneumothorax. If it is S-shape, that is pleural effusion, moderate side pleural effusion. So understood. So that's all. I'll stop here. That
excuse me,
finishes
sir.
pneumothorax. Okay, thank you. Thank you for patient hearing.
Excuse me, sir.
Thank you.
Hello. Excuse me,
Okay.
sir. Sir, the syllabus
Yes.
that was given to us 2 weeks back, sir, that is the final syllabus for the internal assessment exam.
Yeah, that is the final syllabus. That is.
Thank you, sir.
That is the final syllabus. Okay. Okay. Thank you. The syllabus. Okay, చూడమని. Syllabus లో pneumothorax ఇచ్చామా?
Call 20 okay. 20. వచ్చాడు సార్ మళ్ళీ వెళ్ళిపోయారు సార్ మళ్ళీ ఒకసారి ఫోన్ చేయండి వస్తానండి అన్నారు సార్ చెప్పాను అలాగేనండి అన్నారు ఓకే సార్
నువ్వు ఎక్కడ ప్లస్ అయ్యో తెలుసా? అక్కడ వాళ్ళిద్దరిని తప్పించేసి జోన్లోకి వచ్చే చూడు ఇంటి వాళ్ళిద్దరిని